Hi, welcome to another episode of the Cancer Now What vodcast, sponsored by Arizona Center for Cancer Care. My name is Jenny, and I'm so pleased to be in studio today with two of our community's finest physicians to have a conversation about skin cancer and Mohs surgery and radiation oncology. Please help me welcome Dr. Thosani, Mohs Surgeon and Dermatologist, and Dr. Subhakar Mutyala, Radiation Oncologist with Arizona Center for Cancer Care. Hi, you guys. Thank you so much for being here. I appreciate you taking the time to have this conversation.
Thank you for having us.
Thanks for having us.
So as you all know very well, living here in Arizona, skin cancer is something that we all have to be super sensitive about, and we have to pay really close attention to. So I wanted to make sure that we had the opportunity to speak to the both of you, because skin cancer is something that you see in your practice every day, right? And there are different ways of treating it. And so I thought it would be really important to hear how the different specialties handle skin cancer, what a patient can expect when they're diagnosed with skin cancer, and really how they can find you if they need you. So I'll start with you, Dr. Thosani. So tell me a little bit about yourself, your specialty. You're a Mohs surgeon, dermatologist. Tell me about that specialty.
Well, I am in practice for 15 years. I did an internship in general medicine, and then I did 3 years of dermatology, and then I spent 1 year doing a Mohs surgery fellowship. Mohs is not an acronym. It is named after Dr. Frederick Mohs, and it's a procedure where we can remove skin cancer with a very tissue-sparing method, check the margins, and then reconstruct the patient. So I moved to Arizona about 8 years ago, and I've been very thrilled to be out here. It is tied, sometimes takes the lead with Florida as the skin cancer capital of the country. Not really a title we should be proud of, but I'm happy to be here.
Great. Well, we're lucky to have you for sure. And Dr. Mutyala, tell me, so radiation oncology means that you're not just taking care of skin cancer patients, but tell me a little bit about your specialty and how that works in the cancer care world.
Sure. So I'm a radiation oncologist, and that's where we treat cancer with radiation. Skin cancer is one of the most common cancers that we have, and it actually is very amenable to radiation. So that here in Arizona, that is one of our cancers that we do treat a high volume of. Arizona, as Dr. Thosani mentioned, is one of the hot spots in the country for skin cancer, and so it's very important for patients to be evaluated and treated.
Got it. Good. Okay. So, Dr. Thosani, what exactly is skin cancer? And are there different types of skin cancer?
Yes. So skin cancer is a cancerous change in the cells of the skin. There are various types of cells in the skin. So sometimes people think that one type can turn into another type, which isn't as common. But the three most common types of skin cancer are basal cell carcinoma, squamous cell carcinoma, and melanoma.
Got it. And how are they different?
So they're different in many ways. First of all, basal cell is by far the most common cancer. It's more common than breast, colon, and lung combined. Squamous cell is about a fifth as often diagnosed, but it is more aggressive, and there are variants of squamous cell that can spread through the body. And actually, what people may not realize is that squamous cell actually causes more deaths than melanoma. Melanoma is one of the more aggressive types of skin cancer that even if it's caught early, it still has a risk of spread, and it can lead to metastases more frequently and death.
Okay. So what are the risk factors? I mean, we all know don't put baby oil on when you go into the sun, right? Like our parents did to us in the 80s. That was wise. But so what are the risk factors? What can people do to protect themselves from skin cancer?
So the first thing is to essentially treat yourself as being very careful, especially in Arizona, every single day, whether it's cloudy out or not. because the UV radiation can be quite damaging. And so I always recommend sun protective habits. So clothing is really great, and physical blocking sunscreens, such as mineral sunscreens, are ideal. I especially like something over an SPF 30. And then making sure you stay out of the sun between 10 and 2. There's also a much greater risk of skin cancer in fair complected individuals. So type 1 skin would be maybe a very light skinned, redheaded, green-eyed person would be far more at risk from getting a skin cancer than, let's say, someone like myself or Dr. Mutyala.
Or me. Good. Okay, good. That's helpful. Then how do you know if you have it? Like, when do you decide it's time to get something checked? I know you're supposed to do your regular skin checks, but how do you know if there's something suspicious?
So the most common story I hear for a basal cell carcinoma is that a patient has a complaint of a pimple-like lesion that is bleeding and doesn't really heal and keeps recurring and bleeding in the same spot with minimal trauma. They're washing their face or they're scratching their body, and it just continues to bleed in that spot. The most common story for squamous cell is an isolated pink patch of dry skin that just doesn't seem to go away even if they put moisturizer on it. And then, of course, for melanoma, we always harp on about the ABCDE criteria, which is when you look at any brown or pigmented lesion of the skin, is it asymmetric? Does it have an irregular border, more than 2 colors? Is the diameter larger than a pencil eraser? And E would be if it's evolving or changing. So something small can be changing rapidly, and that's what we really like to look for. And we don't like any red, white, or blue colors, so nothing patriotic.
Okay, good to know. And then, so obviously a patient's going to go to their primary care doctor or to a general dermatologist for screening. When is it time for them to take the next step and see a specialist?
So I think that our primary care doctors are really our front line and very helpful, especially in Arizona. They really help to detect a lot of the problematic lesions for the patients. And if they ever have any doubt, obviously dermatology is available for specialty consultation. For higher risk populations, people who have had a tremendous amount of sun damage, people with a lot of genetic history of melanoma, I always recommend that they do an annual skin screening with a dermatologist. And then once you have a diagnosis of a skin cancer, such as basal cell or squamous cell, I usually recommend that they come in at least every 6 months for a few years to make sure that we're not missing anything. But for a diagnosis of melanoma, I recommend every 3 months for a full skin check, for the first year especially.
Okay, good. So there are lots of different ways that we can treat cancer in general, but skin cancer specifically. Dr. Mutyala, tell us a little bit about how radiation oncology can fit into treating cancer.
Specifically skin cancer.
Skin
right?
cancer.
So
that's what I mean. Yes.
So specifically for skin cancer, a lot of times the initial treatment after diagnosis by a dermatologist is possibly surgery. And obviously we have a lot of skin and a lot of places are very amenable to surgery. However, a lot of places on our face are not. And as that's a place that receives the most sun exposure, that's a very common place for skin cancers to occur. So surgery is possible on the nose or ear, but could be very disfiguring, or on the scalp where it's harder to close the skin. And in those situations, radiation is usually indicated. Radiation does have great outcomes from treatment for skin cancer, specifically for the basal cells and squamous cell carcinomas. Radiation does have 95 to 97% control rate without having the same disfiguring issues that surgery could have on sensitive areas like the nose, by the eyes, or on the ears.
Okay. And is it the same kind of radiation that you would use for any type of cancer? They go on the big machine, or is it more of a precise treatment? What does that look like?
Yeah, so for skin cancer, we actually use a different type of treatment. Typically, we'll use something called brachytherapy, because most of our cancers are actually below the skin, so we actually have to use machines that generate really high energy X-rays to get through the skin. The exact opposite is the case for skin cancer, so we just need to treat the skin and a couple of millimeters depth for the cancer. And so we use something called brachytherapy, where we place a radioactive isotope on the skin, and leave it there for a certain amount of time, 5 to 10 minutes. And usually we can do this with anywhere from 8 treatments to up to 16, where the patient comes in daily for those 8 treatments or 16 treatments and sits there with the radioactive source on their skin for 5 to 10 minutes.
Okay. And then they're not left with an incision scar.
No, they do have, over the short term, there is some redness and blistering of the skin that we can manage with some topical medications, but then that does heal up, and the outcomes usually are pretty good, where you can't really tell that the patient had a skin cancer there or radiation treatment.
Cool. So, Dr. Thosani, then how does Mohs surgery fit in for a cancer treatment, skin cancer treatment?
So there are a lot of places on the face that do heal really well with surgery. For example, a man on his cheek who wants to grow a beard, where radiation may eliminate the hair growth there. And then there's certainly people who don't have time to go in for multiple treatments based on their position, their career, their job, their ability to get a ride to and from. So they may opt for surgery. And then there are cases where rarely they've had a recurrence and they don't want to have another treatment, and they choose to have a procedure such as Mohs, where we check all the margins and can chase the tumor and make sure we get it all before we go. And oftentimes, if we have a very aggressive cancer, what I will do is partner with my radiation colleagues, because they'll have a higher chance of cure. If a squamous cell involves a nerve and it tracks down the nerve, I'll often clear what I can see as the visible tumor, reconstruct the patient, and then 6 weeks later, I'll have them partner with radiation to treat a larger area, what we call adjuvant treatment, and make sure that we minimize their risk of recurrence for small cells.
Very cool. So does it work, right? Like, what are the outcomes for both of your different treatment types? Does it grow back? Like, what are you seeing in your practice, Dr. Mutyala, with this brachytherapy?
So the published reports, and I published on this too, is usually around a 95 to 97% quote unquote cure rate for basal cells and squamous cell carcinomas. I think it's important to know that both radiation therapy and Mohs surgery actually have really good outcomes, as long as patients do see the physicians and get treatment early. And it's good for patients to know there are treatment options.
And what about you, Dr. Thosani?
So for previously untreated tumor, we have documented rates that approach 99%. For a previously treated tumor, then it goes down much further because of areas of scar tissue and location. I usually really like to talk with the patient about their lifestyle, their concerns, their fear of surgery. There are some people I would love to send for radiation, but they have issues with claustrophobia and the shields that protect them. They can't tolerate that. So there are times where my radiation colleagues will say to me, this patient, you sent them because they have 3 skin cancers and we can treat them all at once. But these 2 are very amenable. Would you please operate on this one? That will be better for the patient. And really, oftentimes a combination approach is great. I think in general, younger patients, I prefer to do surgery just because long-term radiation, they might have an increased risk of getting another skin cancer, and then you don't want to have radiation done twice in the same field is usually what I've heard. And so a lot of our older patients really benefit. They have a lot more luxury of time, and they have had a lot of surgery, and they really don't want to be cut on. They're on blood thinners, they have labile blood pressure, and they have a lot of issues, and they really prefer radiation, especially in delicate, hard to treat areas where I've now seen that radiation has newer technology and cones and methods for protecting patients. But surgery, I would say, for me, is oftentimes what I would choose as my first option for a good location and a young patient with a very operable tumor to give them a good cure rate.
Cool. Very cool. So tell us a little bit about this brachytherapy. She's mentioning things that made me feel claustrophobic just sitting here talking to you guys. So what is it like for the patient? I mean, they're obviously awake during that experience. They come in, is it a few minutes? Like, talk us through what it's like for a patient who's having brachytherapy to the face.
Sure. So if a patient has a skin cancer on their nose, say, they come in, we place a radioactive source that's about this size on their nose. Usually it's taped down or held in place for about 5 to 10 minutes. And then the patient can easily come and go by themselves. Now, it does require the repeat visits, anywhere from 8 to 16 treatments. But usually the patients can come and go by themselves. They just have to come in and lie down with something on the lesion for about 5 to 10 minutes.
Okay, so it's not like a super invasive process for the patients.
Some could be, but usually those are the more complicated ones.
Okay.
For the typical basal cell carcinoma on the nose, usually it's fairly simple.
Okay.
Without really like taping their head down or anything like that, which we do for much more complicated diseases.
Gotcha. That makes sense. And the surgery, are they awake for surgery, or it's in your office? You don't have to go to the hospital. Like, what is that? How does surgery go for the patient?
So the patient will come to our office and we do all the procedures under local anesthesia. We do, in some cases, have anxiolytics such as Ativan available or Valium for patients who are very nervous, but we bring them in. They have to have a driver who stays with them at the whole visit. And we just discuss all of the risks, benefits, alternatives, go over the consent form, make sure to answer all their questions. Then we provide them this medication afterwards. And then usually 99% of the patients don't need this. We just perform the procedure under local, and then we use 2 different types of local anesthesia, longer acting and shorter acting. So this way, as they're going through the procedure with us, if it takes more than one try to get the cancer out, they're still numb. So we continue to numb them through the day and make it relatively painless. It's also safer for our older patients who have a lot of comorbidities, and really general anesthesia becomes a whole risk for cardiac clearance and having other issues such as MI, heart attack, stroke. And we don't require patients to stop blood thinners. And it's overall kind of like a boring plane ride to nowhere. I tell them to bring a blanket, pack snacks, and just bring reading material or devices to keep occupied. And then by the end of the day, they're reconstructed and happy.
That's awesome. Very cool. So what are some of the most common questions that you guys get when you have a skin cancer patient in front of you and you're about to start treatment, or you're in that initial consult? Dr. Mutyala, I'll start with you.
The main question they ask is, what side effects would I get from the treatment? And realistically, it is redness and possibly blistering of the skin for, around a nickel size or so for these small skin cancers, maybe up to a quarter size. It does heal up, and then that's the main question they ask. They do also ask other questions if they become radioactive or if they're safe to be around other people. And it's important to know that once they leave the department, they are completely not radioactive and very safe to be around children and other people like that.
Use the bathroom in their house, that kind of thing.
Yes.
All good. Okay, perfect. Good. Well, that's good to know. And what are they asking you, Dr. Thosani?
Most of my patients want to know if they will have a scar, which anytime we cut the skin, there will be a scar. Oftentimes, I'll even get this question from a patient who has a large bleeding ulcer, which I will point out will be far improved cosmetically by treatment than leaving it there. They also ask about how long their stitches will be in. If I'm operating on the face in an area with little tension, I'll often try to use dissolving sutures, which will dissolve over about 10 to 14 days. If I don't do that, then I'll remove them in about a week. If I'm working below the neck, we'll often leave them in for 14 days. And then I always remind them that they'll have a scar and that it's dynamic and healing. Scars are about 10% healed about a month after surgery. So as much activity limitations, they're often surprised that they can't just go right to working out or golfing or tennis or hiking or biking. They feel like golf doesn't use their cheek, and why can't they just go out there? So I remind them about all of the activity level and how it increases blood pressure, increases movement and exposure to the sun, all changes the appearance of the scar. And so after about 2 months is when I tell them they can really look at the scar and judge how it will heal long term.
Okay. Yeah, those sound like the questions that I would want to know the answers to, so that makes sense to me. So Are there advances in treating skin cancer? I mean, it sounds like you guys have it pretty well under control, but there's always new things coming out and happening. What are some of the things that are on the horizon that are exciting in the skin cancer world, Dr. Thosani?
So I think for us, it's actually a lot of the chemotherapy medications that are coming out that are specifically targeting basal cell, squamous cell, and melanoma. We have a lot of new medications that we're using for clinical trials that we're seeing very promising results for these cancers. I also think they're using these same genetics of the cancers to specifically target therapies and create topical modalities to treat cancers. We haven't talked about this aspect, but we use a lot of field treatment, which is where you treat a large surface area of the skin that's been highly sun damaged with either a topical chemotherapy or a topical immunomodulating cream in order to help prevent formation of skin cancer and reverse sun damage, build new collagen, reverse DNA damage. So there's a lot of options that are coming up and that are being utilized.
That's so cool. What about you? Anything to add there?
Yeah, I think specifically more for melanoma, there's been some introduction of some immunotherapy treatments for it that previously, if melanoma has spread, it was really hard to control, not just with surgery or radiation, but with chemotherapy and the existing immunotherapy. But more recently, there's some newer treatments that have come out that actually can control some advanced melanomas. And I think that's exciting because that used to be a disease where once it spread, we really didn't have good treatment options.
So medical oncology does get involved sometimes in the appropriate situation.
Yeah.
So when that is the case, or even when it's not, how do you all communicate when you're sharing patients? Are you texting each other? Are you doing tumor boards? Like where is all of the collaboration actually happen? Because I know you share patients in common. So how does that work?
So we do both. We communicate on the phone, via text, and also tumor board. And that's how we definitely can include our medical oncology colleagues. But I think communication is important for cancers like this, where it is multidisciplinary. Like a lot of times a patient might have surgery, and if it gets to be very advanced, like Dr. Thosani mentioned, we can do radiation afterwards. Or if the presenting patient has something more advanced where the cancer is already spread, we do have a good number of organ transplant patients here or immunosuppressed patients here. So for those patients, sometimes these skin cancers, even though they're benign cancers, they could spread. And so for those patients, sometimes we need to have a combination of surgery, radiation, and chemotherapy. And then also for melanoma, we usually use a combination where patients do have surgery a little bit more aggressive than Mohs surgery, but then they follow that with possibly radiation and or immunotherapy afterwards.
I would just like to add that the communication is super important because whenever I've worked with my radiation colleagues, I try to send them via Tiger Text, which is our secure messaging app that we use, photographs because the faxes don't go over well. And then oftentimes with dermoscopy, which is a non-invasive light that I use to look at the skin and sort of try to determine the borders of a skin cancer, because to my eye, it might be different than what the radiation oncologist sees. And so we want to give them the best chance at cure by giving the appropriate field size. And so a photograph that I can edit with the marker and just sort of send. And that way the patient feels like they've already been seen. Even, the radiation oncologist appreciates it. Even if we coordinate with surgical oncology, then the patient really feels taken care of.
That's amazing. So let me just shift gears here for a second and get to know the two of you a little bit better, if that's okay. I would love to understand what drew you to cancer care, why you wanted to be a radiation oncologist, and why are you passionate about your field?
So how I ended up in cancer care is during medical school, I went in expecting to be a trauma surgeon or something like that. But seeing what's going on in cancer in terms of that is a disease that we can treat, but there's also not perfect treatments. And so there's a lot of research to it. We do have to keep reading and learning. And us as doctors are still also scientists to conduct some of that research. those fields those reasons kind of drew me into oncological care. And then looking at the surgery options or medical oncology options or radiation options, I kind of like the radiation options as it actually allows us to treat a lot of cancers for cure, but also has a lot of physics and math involved with it. And then I specialize in brachytherapy, which is kind of a procedural aspect of radiation oncology. And that's where we actually place radiation near tumors or in tumors. And so I did like the procedural aspect of that, but it also lets me be a little bit more invasive with patients with some tumors that you can't really control with the outside radiation. And that's what kind of drew me into cancer care. Of course, we all have relatives that have died from cancer. Cancer is the number one cause of death in Arizona. And so this is something that is very common, and it's only going up. Mm-hmm. And so just to me, it told me a niche of where I could try and help out people, including some relatives or other people.
Of course. Good. Well, we're glad you did, for sure. And why did you get into dermatology and Mohs surgery?
So I am a girl who likes instant gratification. If I go shopping and buy a pair of shoes, I'll often try to wear them out if I can. And for me, in medicine, I needed something that I could instantly feel I was helping the patient. I wanted to be able to see the problem. I didn't want it to be some nebulous thing like hypertension or diabetes. I liked the visibility of skin cancer. I like the idea that I can do things that not only prevent it, but I can operate and get rid of it, as we were just discussing, and giving the opportunity for the patients to have a cure. It was very gratifying to have something that you look at and can instantly feel like you can fix it for the patient. And I just find the science behind the skin, which is our largest organ, very fascinating.
Largest, so most important. Good. That's great to hear. So I always end the show asking if there was anything that you would want people to know about skin cancer that they might not understand or know. What would that be? And I'll start with you.
Well, we kind of alluded to it earlier, but here in Arizona, one of the reasons we're all in Arizona is the weather. But that's a double-edged sword because that actually we have some of the highest skin exposure to sun in the country. And here we are one of the hotspots of melanoma in the world due to that reason. So it's very important to use sun protective either clothing, hats, and cosmetic sunscreen because we do get exposed to a lot more sun here than anywhere else. And so I think using sun protection along with seeing your dermatologist or physician periodically is very important here in Arizona.
Great. And Dr. Thosani, what would you want to make sure that people know when it comes to skin cancer?
I want to make sure that people don't ignore what they think is something on their skin that they Google or figure it will just heal. And there's a lot of stories I hear of patients saying, oh, I was hiking and I think a cactus got me, or, oh, I was cooking and I think that something splattered on my face and burned me, or, oh, I just think it's a shaving cut. And they're explaining away these bleeding or changing lesions on their skin rather than seeking professional opinion. And it really is so treatable if we catch it early and make sure that people that are high risk come in for skin checks.
Well, that is great advice from both of you. Thank you so much. Is there anything else that you all wanted to share with us before we thank you for your time today? Anything you can think about?
No, just want to wish everyone to have a good, safe summer and make sure you wear sunscreen.
Definitely.
I agree. Thank you so much, Jenny.
Of course. Well, thank you both so much for being here, Dr. Mutyala and Dr. Thosani. And thank you for watching this episode of the Cancer Now What vodcast. If you would like information on either of the physicians that you saw here today, you can visit us at www.arizonaccc.com. Thanks.